here and for all you have been doing with the cancer community. Today being October 1st, the first day of Cancer Awareness Month, and we so appreciate you taking the time to be here with us. We also have Sharon here, and she is going to be reading or talking a little bit about your bio and get you to come on and share more with us about cancer awareness.
Dr. Lawrence? Hello. You are looking beautiful, pretty in pink, by the way, Doc. Gorgeous. I mean, the lipstick to the top, and she's in her pearls, Rosalee.
She's definitely representing the
Yes.
breast cancer awareness.
We're just going to, with your long bio, I mean, honestly, I read it over and over. My husband read it. And let me tell you something. I'm blown away. I'm just going to ask you to introduce yourself because I cannot squeeze what you've done over the umpteen years with what you've accomplished. I can't squeeze it in. I'm not going to cheat you on that. So I'm going to allow you to
that's
to
fine.
go ahead and
Yeah, I usually prefer a brief introduction anyway. For those who are watching, my name is Dr. Camelia Lawrence. I'm a fellowship-trained breast surgeon, and I currently work for Hartford Healthcare in Connecticut. I serve as the regional director for breast surgery for two of the Hospital Connecticut and Midstate Medical Center. Other hats that I wear is that I'm also the president of the Fairfield County Medical Association here in and I'm actively involved in the community. My passion is helping women and men who are challenged with a breast cancer diagnosis to triumph over this disease process. So thank you both for having me this evening, and I look forward to having a informative discussion about this disease.
Well, Dr. Lawrence, you've been very modest. So guys, I'm gonna throw this in there because she's not only the breast cancer surgeon, okay? I've been bragging on her because what you've done, you've made us so proud, Dr. Lawrence. So I'm gonna make you blush. I don't care. I have no shame. Okay. So Ringling and Barnum, she was the ringmaster for them. Okay. She's got two amazing young geniuses, her daughter and her son. Okay. And so she has accomplished so much in her time. As far as breast cancer awareness is concerned, she's got a plethora of awards. Accolades. Just recently, as recent as a week ago, the Prime Minister of Jamaica, there was a diaspora meeting. She was right there with them, right on level with the diaspora meeting. She represented Jamaica. Okay, so when we talk about Jamaican ambassador, that's who we're looking at in terms of Dr. Camelia Lawrence. Okay, and I could just go on and on, but she's being very modest, and I get it. Because we're here to get to the meat of the matter. We already lost a couple of minutes trying to get our technical difficulties straightened out, so we appreciate you all for being patient. So we're going to jump right into the meat of the matter. We've got Crystal. I think Donna, is Crystal on? Because Crystal is a breast cancer survivor. She's Donna McLeod, our first Jamaican House representative here in Georgia. She's her daughter is a breast cancer survivor, and she's supposed to be online. So, Donna, are you there? Crystal?
Okay. She's not here. So we'll definitely
we'll get back up with her. We probably lost her for a second.
Right. Okay. Well, Dr. Lawrence, we're so grateful to have you with us today. Like I said, we'll start by discussing some of the recent advancements in breast cancer treatment. Like, what are the latest breakthroughs that healthcare workers, especially those working closely with patients, should be aware of?
The management of the breast cancer patient is dynamic. There are several research at any given time that's underway to help us to better diagnose and treat the disease. Most of the work that's currently being done is more in the medical oncology space, I would say, identifying novel treatments for treating breast cancer. We do know that it's one size fits all, and every
Mhm.
woman that presents with breast cancer, their treatment algorithm and the biology of the disease may very well be different. So many institutions have what's called a multidisciplinary team, similar to what we have at Hartford Healthcare, which is essentially a group of expert clinicians all participating in developing a treatment plan for each woman that presents with breast cancer. I often tell patients breast cancer, the management, it's not just surgery. There are really three main prongs to treatment. Surgery is one aspect of it, but there are some patients who may require all three. There are some that may require one or two, and those are the prongs include medical oncology, whether it's traditional chemotherapy,
Mhm.
estrogen therapy, and there's some that may require different forms of radiation.
That's fascinating. So we know the emotional toll, it takes on patient, and it can be very overwhelming. How do you think healthcare workers can better support patients emotionally through the treatment journey?
Yeah. I can speak to what we do in my location is that we have what's called breast cancer navigators. Uh, from the moment a patient is diagnosed, he or she is paired
Mhm.
with a nurse navigator that helps
Mhm.
to facilitate the journey throughout the entire care continuum. The
Mhm.
navigator is sort of the person that handles any challenges that may present itself that may lead to a barrier in terms of treatment, whether it's getting to a doctor's appointment, whether it's emotional support, whether it's the need for additional financial resources. It's really getting to a patient on a more social and a closer level beyond just the physician patient relationship to ensure that they have also resources and the support to help them to get through the cancer treatment. I think that's an important part of what anyone can do to help somebody that's navigating a newly diagnosed cancer.
Yeah. That is so true because I remember, going through the same journey with my mom, and just having that support there with me really helped me to get through. Having navigators, like you said, was very, very important and very, very helpful because a lot of time the caregivers are so forgotten,
Mhm.
and it takes the whole village, to make sure that the not only the person who's going through it, but also the caregiver have that support. So I also
Absolutely.
want to ask you, what can healthcare providers do to encourage more women to prioritize regular screening? And I know we all talk about self-care, and sometimes as wives, mothers, bosses, entrepreneurs, we put ourselves last. So is there anything that you think that healthcare could, providers could do to really encourage women more to prioritize their well-being and get regular screenings?
I think it extends beyond healthcare clinicians.
Mhm.
Um, it's a community effort. It also involves relationship with your primary care physician and your OBGYN. The current screening guideline stipulates that any woman that's 40 and over should be having an annual mammogram. So for those who visit their doctors or clinicians in general for routine annual evaluation, they strongly encourage to obtain their screening mammography if they haven't had one. I think also just education around what
Mhm.
to look for is important. I often tell women the majority of breast cancer that we find, they're found in imaging through your screening
Mhm.
mammography. But should a woman notice any abnormality within her breast, it should be brought to medical attention right away. And some of these classic presentations include whether it's a lump that you may notice in the breast,
Mhm.
it could be skin thickening, redness of the breast, It could be nipple discharge or nipple retraction or any dimpling in the breast. I often say it's better to be played on the safe side and seek medical
Yes.
attention as opposed to waiting and finding out later that it's something beyond what it actually is. What I also want to add is that
Your turn.
while the screening age 40 here in the United States for average risk women, if you have a family history of breast or ovarian cancer, that age may even be sooner.
Mm.
The majority of breast cancers that we see, we don't know what caused it, but about 10% can be due to a hereditary mutation. And for those who have that mutation, for example, the BRCA1 or 2 mutations are the two most commonly known mutations here. The current standard guideline dictates that you begin screening mammography at age 25.
Wow.
So that's much earlier. So it's very important to know your family history. It's very important to have those conversations with your clinicians so that I think by age 30, you should know what their risk is. Are you part of the average risk for the
Wow.
typical American woman, which is 12%? Or are you at a higher risk where you need to be more closely monitored at a much earlier age?
Well, I'm gonna ask you a question there because you've jogged my memory. I recently, as recent as probably about 9 months to a year, heard of a young lady, a teenager, who had breast cancer. A teenager, I think she was 16, 15 or 16. I mean, that might be rare. Is it? I mean, is that a rare situation?
And it's very, very,
very
yeah,
rare.
it's very, very rare to see a teenager with a breast
With
malignancy.
breast cancer. Right.
Yeah. You know, anecdotally, I'll say in my practice, and I think some of my colleagues would agree, is that we are seeing younger women with breast cancer,
Correct.
women in their late teens or 30s before the recommended screening age, which is why I think self-breast exam still has a role, so that if you were to identify anything in the breast, you can seek medical attention because we're seeing
Okay.
cancer in younger women.
Oh.
Wow. And you know what? We're emphasizing women, but then there are men who have had breast cancer. Can you speak to
Correct.
that?
Yeah.
Because
So,
I mean,
yeah.
the famous Shaft, I mean, and others. I mean,
Yeah. So while the majority of breast cancers that we see are found in women, male breast cancer accounts for about 1 to 2% of cancer cases in the United States yearly, and that translates to about 2 to 3,000 men who are diagnosed with breast cancer. Male breast cancer tend to be associated with the BRCA2 mutation, so there's usually a genetic component to many of these cases. We don't have any screening modalities for men. They don't get annual mammography, so most often when they present, it's usually they felt a lump in the breast or have noticed some abnormality within the breast. But you're absolutely right that men can get breast cancer. And we get half of our DNA from mom and half from dad. So if there's a genetic component to it, both men and women tested within the family to see if there are carriers of that particular mutation.
Interesting.
Wow.
Interesting. And we've talked about support groups. We've talked about the village. But you know what? We have to speak to those who don't have a village. And so how do they really get the help that they need? I mean, okay, fine. They may not have, because people are, how would I say, shy about their bodies or embarrassed or just scared, just petrified. You know, if someone gets a diagnosis, and I know you've heard it, Doc, where it's almost embarrassing to have cancer, period. You know, it's like, oh my God, I don't want to tell anyone. Please don't share it with anyone. And if you don't open up about it, you know, would it be a crime then to just say, hey, you know what? I know my neighbor has cancer. What can I do to help him or her? What does that look like? What would you recommend in a case like that? If someone shares with me that they're going through this, I don't want to keep that secret at all. I would rather
Yeah,
break their
I think
trust.
there's yeah, some of it is cultural as well, and
Yes.
it's a genuine attempt to destigmatize cancer.
Mm-hmm.
I often tell my patients that this is nothing that you brought on
You
yourself.
brought
This is
on.
not
Right. It's
something
not a
that
Mm-hmm.
curse.
Yes.
it's not something that you bought at the store that you can return. This
Mm-hmm.
can
Right.
happen to just about any one of us.
Anybody?
Could
Yes.
be diagnosed with any form of cancer. I think in those cases, what you can do is look at the resources that are accessible within your geography. I know I can speak to here in Connecticut, there are different support groups, there are different advocacy groups, there are different survivor groups who are willing to pair up with another man or woman who's dealing with a similar cancer diagnosis and sort of form like a supportive buddy partnership to help them navigate through the care continuum. But you're absolutely right that fear is a big part of the delay in seeking treatment, often, as well as the
Yes.
delayed diagnosis. And you try to underscore that fear is not a strategy. And one of the things that we know, especially about breast cancer, out of all the cancers that we deal with, is that breast cancer is actually one of the most treatable cancers.
Mm.
When caught early, breast cancer is treatable. It's not a death
Yes.
sentence. For example, women who are found with stage 0 breast cancer, which is also known as ductal carcinoma in situ, the 5-year overall survival is 95 to 99%. So the
Wow.
majority of women
That's
are
amazing.
having their surgery done, having it taken care of, have their radiation, what's needed, whatever is needed, and they go on to lead normal lives. But that's
Yes.
because they were vigilant, the disease was caught early, and was
Mm-hmm.
treated appropriately. So, try not to bury your head in the sand because the
Right.
later your diagnosis, the prognosis is worse in that case. So you take somebody with stage 0, survival is 95% of 5 years.
Mm-hmm.
In contrast to someone with stage 4, that's disease that's left the breast, it's made its way to the lymph node, it is now in other
Mm-hmm.
visceral organs such as the
Right.
bone, the
Mm-hmm.
liver. Those patients have a 5-year survival of just 24%. So look at the
Yes.
difference
Yeah.
just in
Yep.
terms of
That's
stage of
yeah.
diagnosis.
Right.
It's
And that,
caught,
that is
the
so
better.
yeah. That's so true and so amazing. Me. Like what Dr. Lawrence said. Just like check your body, being in tune with your body. You'll find a lump. Reach out to a healthcare provider. This is not something you brought onto yourself. Getting treatment early save life, because that's the same thing with my mom. She was 84 years old when she found the lump. When we took her in the same week, she had the biopsy. It came back. She was triple negative at 84 years old, and she was able to have surgery, 35 rounds of not chemo, radiation, and live for 5 years. So can you
Mhm.
imagine if we had caught that early, if we had known how much more that you'd have given her lifespan, would have given her.
Of course.
Yes.
Mhm.
Wow.
Yeah.
I'm
It's
going to
amazing.
segue a little bit, Dr. Lawrence. What led you to this great, campaign, this real, because it takes a special kind of a person to do what you do. How did you dream this up? Where did this come from? I mean, it
Ah,
came from somewhere. Okay, you were brilliant, you were an A student in school, whatever. But what led you to this dream job, this thing that you're helping so many patients around the globe? I mean, you've helped a plethora of people. What led you to
mhm.
this?
I often say it's not a job, it's a calling, it's an answered
It's a
Mm-hmm.
calling
calling. It sure is.
on my life.
Amen.
I've always been interested in healthcare and in medicine in particular. I think it started for me as a little girl growing up in Jamaica in the rural countryside of Montego, Jamaica. And I remember growing up, and my grandfather, he was afflicted with epilepsy and not having the access to the treatment that was needed for something that's so treatable. I remember saying to myself as a little girl, when I got older, I was going to fix grandpa. Fast forward a few years later, my parents emigrated here in search of better economic and education opportunity for us. And I had the opportunity to, attend college and medical school, and I was really fascinated by surgery. One of the first women that I shadowed in the operating room was Dr. Gretchen Orange. She was a surgeon, and she was a breast surgeon. This is what she did. She made women whole again, and it just really, I
Amazing.
was smitten. And I, for the first time, was able to envision myself fill in that role and really having an impact in a way that I found fulfilling. So here I am today, a decade and a half later, as a surgeon.
Wow. That's amazing. You've made us really proud, Doc. You really have. And I'm just going to say it publicly that, I mean, I'm so honored to be connected to you because of what you're doing. I mean, saving lives. I mean, this is a major thing. You're an angel.
Oh,
You
well,
really
you're
are.
kind. Well, thank
You
you.
really are. I mean, what you're doing is just very impressive. And it's bold. It's a bold move to decide, hey, this is what I want to do. I want to go out. I want to help people. You're like the
Yeah,
superwoman.
yeah.
And I thank you for
Well, it's
that.
about being a part of something bigger than myself, being a part of a
Yes.
solution to a
Yes.
problem. Here, 1 in 8 women will be diagnosed with breast cancer throughout their lifetime. So imagine going out for coffee with your friends, 8 of you, one of you will be diagnosed with breast cancer.
Wow,
Great.
that's
We've got
just,
Donna joining
yeah,
us there, Donna
yeah.
McLeod. So, Donna, can you hear us? Hey, Donna. I think she's probably frozen. Hey, Donna.
Not
Yeah,
sure if she can hear. So maybe we could go in next question for Dr. Lawrence. Then we can bring Donna back in.
I mean, we're mastectomy as opposed to lumpectomy because a lot of words, big words, and as we call it. I mean, we can toss words around, but do we really know what that means? And I mean, when we break it down, Doc, and we say examine yourself, what are we looking for? I mean, when abnormal lumps, dimpling, whatever, the nipple, drainage, whatever. Are there any other signs that there is a problem? Because I mean, I've heard of hidden signs. In other words, hidden what should I say? Detection. You can't detect it. I mean, it's like breast cancer hides. I've heard where people don't
Yeah,
realize until later on.
yeah. So, like I said, the majority of breast cancer tend to be identified on imaging, which is why it's important to get your mammogram. For example, breast cancer can present as a cluster of microcalcifications. You're not going to appreciate that on an exam. I am not going to appreciate that on a clinical breast exam either. But by getting that mammography imaging, you are able to see the clustering of
Yes.
calcifications, which will then lead a radiologist to recommend a biopsy that will clinch the diagnosis of breast cancer. Some women don't present with abnormalities within the breast itself. They may present with an enlarged lymph node in the armpit. So it's very, very important to know your body and to also be sure that you are getting the recommended screening imaging. Now, when we talk about mammography, I think it's very important that we discuss the topic of density because some women have very dense breasts that even after obtaining a mammogram, it may not reveal the cancer because the cancer is hidden within dense breast tissue. So if you're has dense breasts, you should always advocate for yourself that in addition to mammography, not as a replacement, but in addition to mammography, you also be getting a breast ultrasound. The ultrasound offers another diagnostic modality of looking at the breast tissue, scrolling through the breast tissue to ensure that there's nothing hidden within the tissue. And oftentimes, if there's something within the dense breast tissue, you can pick it up on ultrasound.
Interesting. Interesting.
Mhm.
You answered my question because I've heard of that on numerous occasions. I mean, women having dense, I mean, like seriously dense, fatty tissues, so to speak, because you're looking at her. I was told that. And I mean, I had a scare once and I'm like, oh my God, I'm good. So they rushed me back in, checked me again, and they're like, we did the ultrasound, did everything, and you're good to go.
Mhm.
But it still means that I have to be proactive
Yes.
and I have to be attentive.
Mhm.
And that's what it calls
Yeah.
for.
Yeah.
Wow. That's pretty
Absolutely.
interesting.
Mhm.
Man.
It is. It's
That's
it's
loaded.
it's a
I mean,
lot.
that's really,
Yeah.
really loaded. But you know what you're doing is sending me to do homework because I think Donna is joining us again. I think she's coming back. Donna, we had her come on, but let's see. She's back. Hey, Donna. I think so. Yeah, there she is. Yes. Okay, now we can hear her. Can you hear us, Donna? No, she's muted. We're not hearing her.
Oh.
We're seeing her, but we're not hearing her.
Okay, so
She's
we'll
waving.
we'll keep going until
Okay,
she
And we'll see.
going.
We can hear you.
Yeah, she's waving.
Yeah.
We know that after being diagnosed, it really take a strong mindset, and that will help to make all the difference. So, Dr. Lawrence, what are some of the things that you could suggest that patients can do to ensure that their treatment plan is definitely fit for them? Because we know it's not one size fit all. So what can they do to make sure that their treatment plan is truly personalized to fit their
Yeah.
needs?
Yeah. Well, I think, the sagest counsel that I have is to tell a woman if you're diagnosed with breast cancer is to ensure that you're plugged into a multidisciplinary cancer center. That means that they'll have a team and infrastructure in place to provide you with the care that's needed. You do want to make sure that you are working with somebody who does this for a living.
Right.
It's not a one-off case that they're squeezing in. They haven't done this years, but So I think the best way to assure that you're receiving the quality care is to be plugged into one of these NAPBC accredited breast cancer center with a multidisciplinary team that can help to provide guidance. If at any point you have doubt about your care or additional questions, there's nothing wrong with politely obtaining a second opinion. I often patients who see me and they have additional questions or they ask about a second opinion, and I strongly encourage them. It's your body, it's your life. You have to make sure
Exactly.
that the decision that's being made it sits well with you and that you're comfortable with that practitioner. So have them get a second opinion. And if you're offering the state of the art, the correct treatment, you will have no problem as a treating clinician with the patient getting a second opinion because you know that they're going to be told the same thing
Right.
else.
Exactly.
But second opinion may help to reassure them and give them that confidence that they need. So that's another approach.
That is so helpful. And I like
It
the
is.
way you said,
She's friendly, yeah.
if they have the patient best interest at heart, they'll definitely encourage for a second opinion
Of course.
because they know they're going to hear the same thing anyway.
Yeah, and sometimes people just need to hear it from more than one source.
Right.
That
Reassure us.
Yeah.
exactly like
Yeah.
this is what's going on. This is what's recommended. Here are the next best steps.
Yeah. So I want to shift now to the survivors. Here we have cancer, we have gone through the treatment, and now we are on the up end. But it doesn't end there, right? It's a journey, and it's a lot of challenges to face. So what are some of the common post-treatment hurdles that survivors face, and how can they navigate life after cancer?
There are different phases from the neuropathy that comes with chemotherapy. Some women may have issues with sexual dysfunction. There may be some image challenges for especially women who've had to face a mastectomy with or without
Right.
reconstruction. And that's where the different resources that comes in to help a woman navigate cancer care because like you mentioned, it's not just during active treatment, it's also post-treatment and helping them to
Right.
thrive during survivorship
Of course.
and having those resources available that they can access.
Right.
Yeah,
A lot of people think that
reconstruction.
life ends,
Mhm.
after. So
Yeah, I mean, you do the surgery, you
yes.
whatever, and then you move on. But like you said, there not everyone is. I mean, they may be able to get to that stage where they can treat it,
Right.
but then as far as reconstructive surgery, I mean,
That's another
the
thing. Yeah.
very few people, I would say. I don't think a heck of a lot of persons are able to get to the next level. What would you say about that? What does that
Well,
look like?
I think luckily I can say the majority of women do rebound after their breast cancer. If you're undergoing a mastectomy, it's a bit of a lengthier process. If it
Right.
includes reconstruction, because reconstruction sometimes involves multiple stages. So that can take a while. But I think with the appropriate support infrastructure in place and the resources that's needed, most women are able to navigate their way through and enter into survivorship and are able to thrive during survivorship. The goal of treatment, I often say from the outset, is really to get folks to get back to a way of life prior to their cancer diagnosis.
Yeah.
To not be defined by your cancer, but to hopefully return to some semblance of normalcy of what you had
Yes.
before this diagnosis.
Right.
Right.
And like for many survivors, the lingering, because these are conversation I have with people who have gone through cancer, the recurrence is always lingering in the back of their mind, right? They constantly live in this fear of it coming back. What advice or encouragement or suggestion you have to help to get over the fear, other than therapy? Because that's the only thing I could definitely
Yeah. I
recommend
mean,
to them
it
before now.
varies patients to patient. That fear is very real. And it's understandably so, but I often encourage women, there's not much you can do in terms of the recurrence piece of it. You've done all that you possibly
You can
can,
do.
completed all the necessary steps of treatment. I think sometimes it's just reassurance. I've had patients who come in a little bit more frequently to be seen if it's just for a clinical exam. They just want to hear the word that there is no evidence of disease.
Right.
That reassurance piece. But I think over time, for most women, that gets a little bit less and less. It's almost like PTSD, when you get an initial
It is.
diagnosis and
It is.
you're somewhat traumatized by it. And
The
then,
shock.
with time, a tincture of time,
It lessens.
as you move away from the initial diagnosis, it becomes a little bit more manageable day by day.
Yeah. Especially if you have a good support team.
Yeah, makes a big difference.
Yeah, and that's the key to everything. Is
Yes.
best support.
Yes.
You can't sit curl up and die. You just have to reach out and just keep reaching out.
Yeah.
But not everyone.
Well, there's data that
has
shows that
personality.
there's data that shows that a positive outlook helps to boost the immune system.
Correct.
Yeah.
And
Of
I
Mindset.
do
course.
feel
It's
that
everything.
I feel like
Yes.
those who are more upon their approach, they tend to do better overall. It's that
Correct.
fighter spirit.
Right.
That is correct. That's correct. I mean, I've seen, and you're right about that part, because it's easier said than done. But when you get to that place where you decide, you know what, I shall live and not die, you're gonna fight with every fiber of your being to live, and it most times works. Mind, like they say, mind over matter.
Yeah.
It really makes a difference.
Yes.
It makes a difference.
It makes a difference. Survivorship. But the key is early detection. Get your mammogram. Early detection is key. It saves
How early
lives.
would you say? Again, I mean, can you recap that? How early would you say? Would you recommend?
The current guideline states that for the average risk woman, you should begin screening mammography age 40 yearly. However, if you have a strong family history of breast cancer, you should actually have a formal risk assessment. And for example, if you were to say that my mom had breast cancer at 30 or 35, Well, the screening age for you, it's not going to be 40 because you're not average risk and your risk is most likely going to be higher. So those are conversations that you really need to have with your primary care physician or your OBGYN to see, one, do you meet criteria for genetic testing? And that will also provide some insight as to when you need to begin screening.
Okay.
Wow.
Well, we have folks that are going to be coming on to ask questions.
Yes, but
We're going to
yeah.
have some questions for you if you have a minute.
I'm not sure if they're ready. So if you have any other questions, you can go ahead.
Hey, we are going to bring in audio from one guest at a time. That's
Dr.
what I
Lawrence?
see. And I said, we
I can
cannot
hear
hear
you.
the interview. You're muted.
Right. But I just got a pop-up message saying
Okay.
saying to unmute, but that's not what the problem is. The
Yes.
problem-
Okay,
It's
so they're
not,
getting ready to
no,
ask
it's
us some
them that's
questions.
muted in
Yeah.
the studio.
We have some
Right.
questions for you, Doc, from the audience.
Okay. I'm all ears.
Okay.
Thank you so much.
Mhm.
Okay.
Oh, shit.
Hey, Debbie, go ahead and ask your question. If you have a question for Dr. Lawrence, go right ahead, please. Debbie, you're muted. Go ahead and unmute, Debbie. Hey, Debbie, are you hearing us? To the bottom left.
All right. Picture. Yeah.
Okay, go ahead. There she is. Debbie, we can hear you if you can hear us. No, I don't think she's hearing. We're gonna go ahead and
Debbie, can you drop your question in the chat?
yes. We're just gonna go ahead and move on to Simona.
There was another person.
Is there
Sorry.
anybody else?
I can
Crystal's
push this
on.
screen.
Hey, Crystal? Not sure if she's hearing us either.
Is there any more questions? Do you want to ask them?
There were some questions in the chat. Does somebody want to read those questions that are in the chat?
There are questions in the chat. We can see it.
Can you take the picture?
Okay,
Nick?
so we're
Darren.
getting our engineer.
Yeah. You go ahead and ask another question until it comes up.
Are there any other patients when they're deciding what kind of surgery to do? Is there anything specific, or does it depend on the how would I say, the magnitude of the disease? I mean, what's going on, really, what stage it's at? I mean, the doctor, the surgeon determines that. Isn't that correct?
It's a collaborative decision in terms of surgical management. So whenever a woman has breast cancer, there's really two options for treating the cancer surgically. One is the lumpectomy, removal of the area of the breast with the cancer along with a rim of normal tissue around it. And secondly, a mastectomy, removal of the whole breast. And some of the factors has to do with, one is the size of the tumor. For example, traditionally, a woman who presents with a tumor that's greater than 5 centimeters most likely will need a mastectomy in most cases. Because 5 centimeters is such a large area of tissue that if you were to do a lumpectomy, it would result in such a large deformity of most breasts that you would have to remove the entire breast. But for the majority of women, I would say they have the lumpectomy, which is also considered as breast conserving surgery. It's tumors that are smaller that you can remove with a rim of normal tissue around it. If it's an invasive cancer, most often a sentinel lymph node biopsy is done along with the procedure. So those are really the two big factors. Now, patient autonomy takes precedence. I will say We've had an uptick in mastectomies, including bilateral mastectomies, because there are women who come in and they're saying, I don't want to deal with this ever again. I just want to have
Yeah.
both breasts removed.
I've heard that.
Also, if they have the genetic mutation, such as the BRCA1 or 2, the recommendation would be to consider bilateral mastectomy.
Got you. I think,
Yeah.
Doc, you know what, guys? I'm going to ask you to raise your hands, because if you're putting it in the chat, you're probably not unmuting. We can't hear. So just drop the questions in the chat for Dr. Lawrence, if you could please. Just raise your hands if you have a question, as the alternative. So I'm not sure if Debbie is back with us, because I know Debbie was trying to ask a question. And is there anybody else who has a question? You could just go ahead and raise your hand.
Yeah, we're asking for anyone who have a question to raise your hand.
I think they're probably not finding that unmute button. Doc, is there anything else before we go? Is there anything else that you would, just one final word or final nuggets that you would share with the audience? Again, I mean, especially with, we don't wait for October,
Yeah, don't wait for October to be vigilant about your breast health. I think it's great that we have a month to create the awareness around this disease, but awareness of breast cancer, it's a year-round initiative. We've talked about what's most important here. We talked about, the importance of seeking medical attention for any abnormalities within the breast. We talked about screening mammography. I think another point that I would make is for every woman to understand is that the majority of women that we see with breast cancer, there's no family history. They are the first in their family to develop the disease.
Wow.
So family history, while it's important, I often see women who say, no, it can't be breast cancer, Dr. Lawrence. It doesn't run in my family. There's no one in my family with disease. Well, you are a part of the 75 to 80% of women, in the sense that no one in their families had the disease, and they are the first one. So just be vigilant about your breast health, and just know that early detection is key, and breast cancer, when caught early, is a very, very treatable disease.
That's such an important balance to strike.
It is.
Very important. So lastly, Doc, for caregivers who might be feeling overwhelmed by demands of caring for a loved one who's going through cancer, they may just have found out, or the person may just have gotten surgery, or it has just come back. What resources or tools are out there, or that you could recommend that can help them to cope and just to just to survive, just to stay ahead?
It's happened. Everybody needs support, including caregivers. I think it's looking into the resources that are available close to home. The American Cancer Society comes to mind for me as a great resource for anyone dealing with any cancer, including caregivers. Susan is another national organization that helps to provide resources and support for patients and family navigating breast cancer treatment. So, and there are other, just about every town or state, there are different state programs, there are different resources that are available to help provide support. And if you're plugged into one of these breast centers or cancer institutes, they usually have resources, or at least a catalog of places that they refer patients as well as their caregivers for to obtain additional support as needed.
Right. And I know a lot of communities have nonprofit organizations that they use for that. Because I too founded something after my mom. My mom was diagnosed, called Rosalee Cares, and we actually help parents who are in the postpartum period and are coping with cancer, or is a caregiver of someone who is coping with cancer, where we provide respite care for them, or some we actually provide postpartum postpartum care for them. So there
Yeah,
are
very
things out
important.
there, yeah, that really help.
Yeah, very, very important. Well, thank you, ladies, so much for
Well, we
having
want to
me.
say
It was great to join
we
you
want to
and
thank
share
you
my
very much.
expertise.
Thank you so
Absolutely.
much.
We thank you
Before you go,
again.
Dr. Lawrence, I want to make sure I check Zoom to see if there's any question in the chat. I know you said there was someone put a question in the chat, so let me
Yeah, there's
see.
a question. We got about a minute here because I have to hop off at 8 p.m.
Okay, so you said there was no chat? There was none there? Okay, well, with that said,
Yes.
we'll definitely wrap up. Thank you so much, Dr. Lawrence, for giving us such valuable insights about I was going to say
Right, of
postpartum
course,
care,
breast cancer.
about cancer awareness, cancer awareness, because
Yeah.
that is just as important
Yeah,
as postpartum care. So Sharon, do you
absolutely.
take it away?
I'm in awe. I just want to say thank you again for your expertise. I mean, thank you for your love and for what you do. I mean, and what you continue to do. You know, we just honor you for that. Thank you so very
Well,
much for
thank
your
you.
time. We
Thank
appreciate
you
it.
so much for
We
helping
look forward to talking
to
to
spread
you.
the word.
Yes.
Yes,
All right,
and
take
we
care.
are.
Bye-bye.
Thank you.
Absolutely. Have a
Bye-bye.
good one now. Bye bye.
Bye-bye.
You too. Bye-bye.
Thanks.